Hi, everyone. It's great to be with you all today, and I'm just so excited for this presentation. I know that this feels very timely because of the high number of consults that we've been getting in this area, and so it's my pleasure to introduce our colleagues. Andrea Pedersen is a nurse practitioner who cares for children, adolescents, and young adults with endocrine disorders, including early or delayed puberty and growth disorders and thyroid disease. And she provides comprehensive health care for gender diverse patients at the UCSF Child and Adolescent Gender Center, where she also participates in research to improve treatment guidelines on gender affirming medical care for youth. She's played a key role in the expansion and development of the Child and Adolescent Gender Center at UCSF in Oakland in 2016 and its expansion into the East Bay and San Ramon. And she has also served on the Gender Advisory Board and Work Group at UCSF Benioff Children's Oakland, which is dedicated to the rights of patients in both the hospital and wider community. The group has implemented gender affirming hospital policies, establishing gender neutral bathrooms, and updating EMRs to respectfully collect preferred names and pronouns. Kristin Avicolli is a licensed clinical social worker with over 20 years of experience. She earned her Master's of Social Work from the University of Washington in Seattle in 1999 with an emphasis on health and mental health. She's been working at UCSF for over 15 years, and she's been a part of the Child and Adolescent Gender Center since the clinic expanded to the East Bay. She helps to facilitate conversations between young people and their families around gender identity and provides advocacy and support. And she also serves on the Children's Hospital Oakland Gender Work Group, whose mission it is to ensure respect for all gender expansive patients and families. She is also an active participant of Mind the Gap, a mental health consortium of gender specialist providers, and she provides consultation and education to Gender Spectrum Conference and the Transgender Subject Summit. And last and certainly not least, Dr. Diane Ehrensaft, who is a developmental and clinical psychologist in the San Francisco Bay Area and an associate professor of pediatrics at UCSF. She's the director of mental health and founding member of the Gender Center in partnership with UCSF and community agencies. And she also heads Mind the Gap. Her research and writing focuses on child development, gender, and gender nonconforming and transgender children and youth. She's published several books and articles in this area and is currently working with Dr. Stephen Rosenthal, who's the medical director of the Gender Clinic, and 3 other sites in the US on a 5-year study funded by an NIH grant to study the medical and mental health outcomes of gender nonconforming youth who are receiving puberty blockers and cross-sex hormones. And with that, I'm going to turn it to our speakers.
Thank you, Petra. We're so excited to be here and really just grateful that you all want to hear about this vitally important topic. So we're going to jump right in to make sure that we have time for questions at the end. We'll try to leave at least like 10 to 15 minutes. Disclosure, we have no conflicts of interest to disclose. Next slide. All right, so just to kind of ground us in this work, we want to make sure that we all remember not to ever make assumptions about gender. So this little comic, what makes you assume that I'm a snowman? Next slide. Okay, basic terms, which I imagine most of you are aware of. But we like to review this with families sometimes too, and youth that we see in our clinic, just to get everyone speaking about the same language, and also to differentiate, excuse me, gender identity from gender expression from sexuality, because oftentimes parents and youth are talking about different things, and it's important for them to understand the intersections of these terms and also how they're so very different. So sex. The body I was born with, right, based on XX, XY, or combinations thereof, such as intersex conditions. Gender identity is who I know myself to be at my core, male, female, or many others, right, non-binary, gender expansive, gender queer, undefined. Gender expression, that's the toys I like to play with, the activities I like to do, the children I choose to play with, the clothes I like to wear, the way I like to move, and so forth. And then sexuality, right? Who I'm attracted to, how I identify, gay, straight, lesbian, bisexual, asexual. So like I said, a lot of families come to us, and sometimes we even get referrals from pediatricians based on sexuality when it's really about gender identity. Okay, next slide. So what is a small t? A small t is a child who is expansive, either in their gender identity or gender expressions. It's also a child who does not accept either the gender that matches the sex they were designated at birth or the social expectations for the roles and behavior of that gender or both. Next slide. So here's a photo album of some small t's. Go ahead. And down in the corner, I don't know, many of you, maybe I Am Jazz. On the previous slide, Jazz Jennings has a show. But anyway, here's some small t's. We just knew everyone likes photos. All right. Thanks. Next slide.
So go ahead and click for the chart here. Hi, I'm Andrea Pedersen. I'm so glad to be here. Thank you for having us. So this chart here just shows a graph of increase of referrals to gender clinics across the world, and it only goes up to 2017. You can see the sharp increase beginning around 2012, 2013, and it just demonstrates that there's just an increase and influx of new patient referrals to gender clinics, and a lot of new gender clinics that are opening throughout the world. And I'll just, tell you that after this slide or after this time period, 2017 to 22, we see these numbers increasing even more drastically. So, for example, in the East Bay UCSF Gender Clinic in 2015, I was following 5 patients. That was 5 patients total in the endocrine clinic. From 2016, when our clinic opened, our gender clinic, to 2020, we were getting about 100 new patient referrals a year to the clinic. And then fiscal year 2021, about 150. And then the projected for 2022 is about 250. And that's just in the East Bay clinic. So you can see that we anticipate that this increase is even further sharpened over the last 5 years. Next slide. I'm going to go ahead and just show a couple examples of some studies that are reviewing some of the mental health concerns in the gender diverse population. This is a small study, 360 youth, and the verbiage in the study is transgender or cisgender, which we know is not inclusive fully, but you can see, there's a concern. There's a 2 to 3 times increased risk across many mental health categories of depression, all the way to suicide ideation and attempt. And it outlines that here. There's been many newer studies that continue to report these same disparities, and it's some of this work that Dr. Diane Ehrensaft is doing as well. Next slide. This is just a bigger study looking at the same risk factors. So almost 1,000 more youth included, and part of that may be that the language includes gender nonconforming, but this is looking at this nearly the same age range, and showing several-fold increase in the gender diverse population versus control in areas like depression, anxiety, and then specifically suicide ideation and self-harm. Next slide. So the next 2 slides are looking at the same study, looking at the protective factors for gender diverse youth. And what the outcomes show is pretty clearly how imperative parental support is in outcomes for gender diverse youth. So the dark blue lines represent a child's interpretation of having a supportive parent. The light blue is interpreted as somewhat to not at all supportive parents. And these are looking at positive conditions when there is support by the parent. So higher self-esteem in relationship to parental support, and across all factors, just pretty clear indications. Next slide. So the same study, again, looking at parental support in respect to negative conditions, And, this is depression, suicide ideation. And then what I want to point out to you is the last area there, suicide attempt in the previous year. So you can see it's increasingly increased for youth who don't perceive their parents as being supportive of their gender exploration. Next slide. Go ahead, Diane.
Mm-hmm. Hello, everybody. I'm Diane Ehrensaft, and I am also delighted to be here. And it couldn't be in a more important time in history for us to all be thinking together. So I want to present to you now something that I made up several years ago when I was trying to figure out how to understand gender in the children who were coming to see us. And so I developed a template for getting a child's gender in focus, which is our goal in every child we meet, is to get their specific gender in focus. So I came up with this idea that a gender spectrum is great. And I had been hearing about a gender spectrum, and it went from male to female, and you could slide along this line. And I thought, well, that's too binary and it's too two-dimensional. So I came up with a three-dimensional idea looking out the window at a spider web. And I thought, a web can really work. So I made up this concept called the gender web. And I think there's more on this slide. So that's each person's unique gender self, and it weaves together nature, nurture, and culture. So here's the threads in the gender web, because we can talk about nature, nurture, and culture, but it's a lot more complicated than just three. So within nature, nurture, and culture, we have chromosomes, hormones, hormone receptors, gonads and primary sex characteristics, secondary sex characteristics, brain, your mind, and socialization, family, school, religious institutions, community, and culture, the values, the ethics, the laws, the theories, and practices of the culture you live in. Next slide. However, I discovered that there's a fourth dimension. So there's a little bit of a twilight fourth dimension to the gender web. So I didn't know how to draw that, but the fourth dimension is time. So each individual alters their gender web as they weave together nature, nurture, and culture over time, which means nobody's gender is static. Nobody's. Next slide. So what about adults in the gender web? Now I'm talking about a child's gender web as they're weaving it together. These are the children who will be coming to your offices. And having just read the science section of the New York Times on Tuesday, we are learning that pediatricians are swamped with mental health concerns in their patients during COVID and perhaps for other reasons as well. And that will include kids with gender stress. So when we think of the adults, and that could be the parents, teachers, us as providers, the gender web is every child's personal creation. If we as adults grab those threads from the child, we're going to mess up that child's gender web, and we're going to leave that child feeling all tangled up. If, on the other hand, we facilitate the child weaving their own personal gender web, then the child feels supported and expansive. Next slide. So we developed something called the gender affirmative model. And when I say we, Andrea's been involved, Kristin has been involved, but it's been an international group of people who have gotten together over the last 15 years to talk about how do we provide the best care we can from what we're learning from being with the kids. And we've come up with a gender affirmative model, which, as you will see in very recent political struggles, is bastardized and given a bad name by people who don't understand it. So I think it's important, and I want to do that right now, to say, look, this is what we mean by the gender affirmative model. And I will say, despite what just happened in the state of Alabama and what is happening elsewhere, as in Texas when they closed down the Genesis Clinic. This model is the ascendant model for gender care, certainly in this country, but also in other places in the world as well. And as someone who has worked on a task force to write the new standards of care for the World Professional Association of Transgender Health, it is the model that is represented in the new standards of care. Next slide. So here are the basic premises of the gender affirmative model, which you will see GAM is often how we shorten it. Next slide. Here's number one. Gender variations aren't disorders. They're infinite pathways of gender, a la the gender web, that no two peoples are alike. That cisgender is only one of many pathways of gender, even though it may be the most dominant one that we know about. Each gender pathway is positive. No one pathway is privileged over another. So that's premise number one. Now we go to two. Gender presentations are diverse and they're varied across cultures, so it requires cultural sensitivity. For every family that comes to our clinic, we need to learn about culture and how culture is metabolized, understood, and acted on in the cultural context in which that child lives. Next slide. Here comes number three. So this is the gender web. Gender involves an interweaving of biology, development and socialization, and culture and context. Next slide. Number four, gender can be fluid. It can be non-binary. As mentioned before, there are so many others besides male and female. Next slide. Number five, gender isn't fixed at a particular moment in time, but it is a lifelong process. So fingerprints, we are born with them and they're the ones we die with. Gender web, we'll start with one, but it won't be the one we'll die with. It'll be very different. What's the same about fingerprints for both the gender web and fingerprints is there are no two peoples who are alike. Nobody's. Every single person's is different. Next slide. Basic premise number six. Co-occurring psychological issues, as you saw, we sometimes see anxiety, depression, and many other ills. If they're present at all, they are typically related to interpersonal and cultural reactions to a child, not internal pathology. Next slide. Number seven. Therefore, if there's pathology at all, it more likely lies in the culture rather than in the child. And I will say that right now, many of us are quite tired because we're dealing with the pathology in the culture, in the courts, in the in media, and in legislation. Next slide. Ergo, gender may be the cure rather than the disease at heretofore was often thought of. Next slide. This means for all of us who are at this webinar and beyond us, it is the responsibility of health professionals to cure this disease by getting involved in the community to ensure gender health for all. And it doesn't mean people have to march in protests, but they have to be able to both provide and speak up about quality care for gender expansive and transgender children and adolescents. Next slide.
So the gender affirmative model definition of gender health is a youth's opportunity to live in the gender that feels most real, authentic, and comfortable for them. A youth's ability to express gender with freedom from restriction, aspersion, or rejection. And as both Andrea and Diane commented, I mean, we really see this in real time with the youth that we see in our clinic. And they come, and if the family has it doesn't mean that the parents have agreed with everything that youth has wanted. That's not what we're saying. It's if they've just said, hey, I'm meeting you here. I see who you are, I'm listening, then there's just those youth, no matter what they're facing kind of outside of that caregiving family system, seem to fare way better. Next slide. So that leads us to the essential therapeutic tenet about gender. There's another, yeah. It is not for us to say, but for the children to tell. And really, we just really need to listen. And that's what the culture and the family system need to as well. Okay, next slide. So here we go. We want to pause and kind of open our minds to possibly a new diagnosis. And we want to call that diagnosis social gender dysphoria. Next. So what's the present controversy? Should there be a childhood mental health diagnosis for gender if gender diversity is not a pathology? In the DSM-5, right, the gender dysphoria of childhood is defined as the experience of stress or distress in incongruence between designated sex at birth and experienced gender identity. So perhaps we're being diverted from the real issue, which is the diagnosis of gender dysphoria belongs to the culture and not the child. And that's how we arrive at SGD, social gender dysphoria, which could be defined as stress or distress experienced by a culture or an individual within the culture when everything they've learned about gender in two boxes is incongruent with what children and adults today are demonstrating about their gender being infinite rather than binary in nature. Next slide.
Is it a boy or a girl? I don't know. You can't talk yet. Next slide. So many of you here are meeting with these families and these youth in your primary care offices. And one of the most important things when these youth present, when any youth presents, any person presents, is to ask someone what their name and gender pronoun are at every visit. And I know and recognize this is a culture shift. It sure has been within UCSF as a hospital as a whole. And sometimes it's not asked and the information isn't collected. And there's longstanding relationships with these patients. And we, in building relationships over time, make assumptions. And one of the challenges that I try to recommend is that if the question isn't asked and if we're not collecting that information, is to try to avoid using pronouns in interactions. So ask or avoid, and we can say, place your child on the table, please, or we can say, can you put her on the table? And that can be very affirming for a child who might be doing or having a gender exploration or feeling incongruent in their body. You'll often be the first professional that parents or even youth make this disclosure or share this information with. And I can tell you that I get a lot of referrals from the community where the disclosure was made and there wasn't any further information gathered in the clinic visit or shared with me in the referral. And there's always a pressure of time, and we recognize that. But as you saw in the slides that were presented earlier, there's a mental health concern for a lot of these youth. And so, click, please. We want to make sure that you're prepared to respond. So first and foremost, thank you for sharing. Thank you for providing that information. Is the child safe? Are they safe at home? Are they safe in their social environments and at school? Are they safe in the bathroom in public? Are they experiencing body distress? Is there a lot of gender noise going on? Are they using a binder? And as you know, the wait lists, unfortunately, in our clinic, and I saw a question in the chat that we'll address, but the wait lists are far too long to access our services. And we are doing a lot to address this in terms of some expansion of our program, specifically in the East Bay and also in the West Bay, to try to decrease that wait time. But in the interim, can we talk about menstrual suppression in the primary care environment? Can we talk about, how we can help? Is there a mental health provider on board? Do they have the support that they need? I think that it's a phrase, it's just a phase. Oftentimes we hear this from parents. And the problem with it's just a phase is that we hope that it just kind of goes away, that it fades away like a lot of adolescent exploration does. Go ahead and click. But while this is a legitimate parental concern, we hear this a lot. Is this authentic? How do we know for sure? What if they change their mind? And what we want to really push forward for parents is, authenticity, especially in relationship to gender, oftentimes is a journey, not necessarily a destination. So instead, go ahead. We want to say, let's see how this evolves. We want to affirm the child, and we also want to acknowledge the parental concerns and fears, and make sure that the child is always in the center of care, but that the parent is also feeling held and supported as well. And that's how our program is very unique, is that we're a family-based program, and we hold the parents' concerns and values, and want to make sure that trust is at the forefront of every patient relationship. Next slide. So as a disclosure, all medications used for the purposes of gender consolidation or affirmation are used off-label. And there are different medications that we look at depending on readiness after there's been a deep dive with the family, with the child, in a therapeutic environment, and readiness has been established in terms of consent. And we look at puberty blockers, which are gonadotropin-releasing hormone agonists. We use these commonly in endocrine for central precocious puberty. It's the same medication. It can be administered as soon as the earliest sign of Tanner stage 2 puberty. And then go ahead. We look at gender affirming hormone treatment, which allows the youth to receive the hormone that best aligns their body with gender identity. And then for some youth, they do access surgery, definitive surgery, which is typically gender affirming chest surgery, and later in life, considering genital surgeries. And so recognizing that medical intervention can be life-saving for some children, not for all, we want to take a little deeper dive into the blockers and hormones. So go ahead. Go ahead. So puberty blockers simply put a pause on pubertal development. So this is when used at the early stages of pubertal progression. And if discontinued, endogenous puberty will continue. There are two reasons a child might be a candidate for puberty blockers. The first is that they're in the process of exploring gender and need more time. So this is a kind of a pause for these children. And then number two, they are already socially transitioned or socially affirmed much earlier in childhood. They're clear about their gender and simply need continuity of care. And so they want to block the potential distress that could be caused by their endogenous pubertal progression. One of the things that we're thinking about from a medical perspective that's really primary is bone mineralization. So sex steroid is required for bone mineralization. This happens during puberty. Once we turn off endogenous hormone, we know that we are also pausing bone mineralization. And when we use puberty blockers for central precocious puberty before the adequate age for puberty, there is very little risk to future bone mineralization. But we know that when we use blockers in puberty, so after Tanner stage 2, what we're finding in studies is that these youth once they either have add back hormone or remove the blocker and allow endogenous puberty to resume, that most youth don't quite have catch up bone mineralization after using puberty blockers. So we monitor for this very closely with DEXA scans, monitoring vitamin D, calcium intake, physical activity, weight-bearing exercise. So all the things that can support bone health. And then we're thinking about bone health in terms of when is an appropriate time to use blockers. So we have a lot of youth that come to our clinic who want puberty blockers well into puberty. They've already been maybe post their first uterine bleed for 2 to 3 years. And oftentimes in those cases, the risk of using the puberty blocker outweighs the benefit because they've already had, development in the chest area. They've already had a lot of pubertal progression. So what are we wanting the puberty blocker to do for this body? It's a very, big conversation that we have for youth when they come in and weighing the risks and benefits. And then other concerns, go ahead, are thinking about frontal lobe development. We don't know. A lot of these questions we don't have the answers to. We know that sex steroid is important for frontal lobe development. So removing those sex steroids from the body for a certain period of time, what impact does that have long term? And then genital development and future fertility, which I just want to touch on for a second because with all the political information that's going on and what's going on in the world, there's a lot of misinformation about puberty blockers, that puberty blockers cause a child to be sterile. And there is no side effect of a puberty blocker on causing somebody or a person to be sterile after use. Rather, if a child starts a puberty blocker at early Tanner stage 2 puberty, and their pathway happens to be add back hormone, then there isn't maturation, and therefore the adding in the gender affirming hormone is what may have potential impact on future fertility, but not the puberty blocker alone. And so it's something that we discuss very thoroughly before starting a puberty blocker for any child in terms of family planning and reviewing what options are available for this child. There's a lot of experimental research going on at UCSF in terms of ovarian tissue and testicular tissue preservation that may be promising in terms of offering these people who want to preserve future fertility and decrease the risk of that hormones cause in the future may have. So we talk about all this. Go ahead. So puberty blockers are provided based on stage, not age. This is one of the updates that were that was enforced in the endocrine guidelines for gender affirming medical treatment. Go ahead and click through this. So a youth is eligible for puberty blockers as soon as puberty begins. This could be at any age, and we basically use the criteria. Go ahead. That it should be utilized based on the stage of puberty. Go ahead to the end, and the best interest of the child rather than the age. Next slide. And then looking closer at gender affirming hormones. So this is estrogen and testosterone. Go ahead and click through. There's 4 bullets. Hormones may be used following a course of puberty blockers. Historically, there was a minimum age for gender affirming hormones. No longer the case with the new Endocrine Society guidelines. We also prescribe hormones based on stage versus age. It's important we learn that youth go through puberty in line with their peers. There's many mental health benefits of doing so. We want to look at the big picture in terms of how this child is doing socially. How are their relationships? How is their mental health? How are their interactions with their peers? How is their relationship with their body? So thinking about all these different areas and their embodiment goals is really going to determine the stage of readiness versus an age. Next slide. So there's a lot of controversies about gender affirming medical treatment for youth. And so we want to just review them. Go ahead and click through. I think there's 7 different bullets. So are the youth too young? Is my child too young? Is their brain even developed enough? I just saw a child this morning, a new patient consult. My mom is, really supportive of my gender exploration, but my dad says I'm too young to know who I am. I'm 16 and I'll know better about who I am when I'm 18, right? Puberty blockers are used off-label. Is this dangerous? Is it safe? We use off-label medications in pediatrics commonly, but there is a call here for more long-term research for this population. And then, are we thinking and considering enough about fertility and future family planning? We're talking to, potentially a 14-year-old and presenting the question of, how do you feel about future family planning? And it's a very difficult conversation to have with a youth. And oftentimes, the parents and youth aren't on the same page. And so we have to present this information in an age appropriate and also, not without bias in terms of what family means to every individual. Again, we need to have more long-term research about the long-term outcomes of these medications specific to this population. Should people just accept the bodies they were born with? Why are we interfering with that? And is it okay to change your gender? So these are all questions that we face clinically, and wanting to do so in a way that feels affirming to the child, but also recognizing the legitimate fears and concerns coming from the parents as well. Next slide. Go ahead, Diane.
Okay, so this is just a summary. What do we know at this point about the small t's, the gender expansive and transgender children and adolescents we work with? What we know, number one, is we don't live anymore in a gender binary world, or at least the kids certainly are not living in that world. What we know is gender is born. There indeed are some biological components of our sex, and perhaps that translates to also some things about our gender. And we also know that gender is made, that there is a social construct of gender that changes historically and from one culture to another. Next. We have learned indeed a child is capable of knowing their gender. I was trained as a developmental psychologist, in which I learned that by age 6, a child should have a steady, stable understanding of their gender. I also learned that they should know there's no backsies on that, which we know that part's not so. But now we have this double standard that for cisgender children, we expect them to know their gender by age 6, but we're telling transgender children you couldn't possibly. And we see they can. Next one. Gender identity is not a child's choice. It's a part of one's being. The choice will be how they express or don't express that to the world, I should say, based on their own ability to do so or other people's choices for them. But who you are inside, you own that, whether you share it or not, or even whether you're consciously aware of it or not. Next one. As I said, the choice is not an identity. The choice is actually in expressions and also communication to others. How do you want to present your gender, embody it, and also tell others about it? Next. We now have data that children do best psychologically when affirmed in their gender. In our trans youth care study, our Foresight NIH study, we are just publishing some of our first results on mental health, looking at youth from baseline when they started hormones to their first follow-up. And what we found is indeed there's an upticking in positive mental health aspects and a reduction in gender stressors and psychiatric issues. Next one. We obviously need more research to learn more and to settle these controversies. And I would say, I may be in the next bullet, but I'm going to add it right here. It's not just research. We also need to do what I call gender literacy. We need to communicate what we're learning about gender and what is misinformation that people are imparting about what we do. For example, that we are sterilizing young children, that we are doing surgeries on 6-year-olds to change their gender. Now, all of this still makes a lot of people very nervous. Next slide. So I want to just say in conclusion, this is something that actually happened early on in the San Francisco site of the Child and Adolescent Gender Clinic. So it went like this. It was a 9-year-old patient who had socially transitioned from male to female at age 8. And here was the question posed. What would you do if someone told you that now it was time to go back to living as a boy? And here was the emphatic answer with not a moment hesitation. I'd take him to court. And then there was a pause and came, or they can take me to court. Next slide. Thank you. And now I noticed that there were several questions. So we are going to open it up. We have a little more than 15 minutes to be able to all talk together.
Fantastic. Thank you so much for this very informative presentation. As you mentioned, there are a lot of questions here. So I'm going to start pitching some of them to you. How do you interpret this really striking rise in trans-identifying patients? Is it possible that some kids experience themselves as trans as a way with coping with other conditions or maybe stressors in their lives? So I'd love to hear your thoughts on.
I'm going to take a first stab and then invite all three of us to answer this. Of course, it's possible that gender can be used to work on some other issues in life. And that's one of the reasons we do a deep dive with every child who comes to us. We absolutely have seen an astronomical rise, one, in the number of kids who are simply saying, I'm not the gender you think I am. They is the new pronoun on the street for many, many kids. The reason is not because of a transgender craze. It's not because of influencers in social media. It's not because of providers who have a transgender agenda. There may be a few who do. I think it is because we have a gender evolution that is now turning into a gender revolution. The culture used to be gatekeepers about anybody who wasn't clearly a boy or clearly a girl. Now we have the reverse. We've opened up the gates to say, you can be who you are. So what has happened is people are coming out from under rocks that wouldn't have 50 years ago. And they don't even have to come out from under a rock. They can just walk down the street. So many elder transgender people say to me, I so wish we had people like you around when I was a kid. I just had to stuff it or not even admit it to myself, or they might take their life because it's too hard to live one. So I would say there's an evolution, and people like me who at the beginning of the 21st century started writing about gender and sexuality don't come in two boxes. They're really multiple. We created the talk, and now the kids are doing the walk. So I would say that the gender revolution is being led not by any of us, but by the children and the youth. And Erik Erikson said a long time ago that adolescence is a time of identity exploration. So we've now thrown gender in the hopper. It's not a given. It's not a bedrock. It's something to explore. And so our challenge as providers is to say, okay, this is poetry in motion. So how do we differentiate the kids who are trying it on from the kids who are saying, I either recently discovered, or I knew it a long time ago, but I wasn't going to tell anybody that I am gender expansive or I am transgender. Many of you have heard of rapid onset gender dysphoria, this sudden burst in adolescence, particularly early adolescence of, guess what, mom and dad, I'm not a boy, I'm a girl. I'm not a girl, I'm a boy. And I would say the real diagnosis, and that's not a diagnosis either, but if I'm going to play with diagnoses, it's rapid onset parental discovery. So that parents are often the last to know rather than the first to know. And so we now have data that sometimes kids have known for 8 years before they tell anybody else either about their sexuality or their gender. So that goes back to, I'm going to stop there, but one of the questions that's so poignant is, we're a family-based model. How do we help parents negotiate something they never saw before, they don't know anything about, and it's not what they signed up for? I'll stop there.
Thanks, Diane. I think you did a really good job with that. I'm just going to add and just piggyback. Yes, culture shift for sure. But also I think there's access, there's somewhere to go. I can't tell you how many youth I see who have wanted to access care for years and years and years and didn't have the language to ask, didn't even know what was going on. They'll say something like, something felt weird. I knew something was wrong. I've been struggling. These have been my struggles. And it wasn't until more recently where I found the language and I know where I can go to seek medical care. And I think that's just the increase in gender affirming medical providers as well. I mean, we didn't have it in the East Bay Area of California until just 7 years ago. So.
Wonderful. Thank you so much.
Yeah. And just to add to that too, I think there's kind of maybe an assumption that the youth come to us having it all figured out. And that's definitely not it. I mean, part of what we do in clinic is help these youth and families kind of not know where they're landing and have it all figured out, but just having those conversations about gender exploration and knowing that not every gender exploration lands in a medical intervention either, right? And some of these youth are very okay internally with their bodies, and they just are struggling with the outside world and expressing in the way that they want to express. So we leave all options open on the table, and really it's about following their lead and their pathway and their journey versus that there's, certain ways to do gender. But I guess that didn't totally answer the question, but I just want you to know that we see so many different youth coming in so many different ways, ages to our clinic that I think before we're not even accessing the gender clinic, right? So now they're getting referred from all of you.
And I want to just tell East Bay story about that, about our clinic. This was actually before the clinic really consolidated, but there were people providing care at Children's Hospital. And this was 2008. And this is I'm talking about the concept of mirroring, being able to find yourself pictured and say, oh. So in 2008, I did an NPR show on gender expansive children. And the other speaker was somebody who followed a pretty much reparative therapy model. But I talked about what I was learning about gender. And there was a youth listening with his mom, a teen, listened, and as soon as the program was over, he turned to his mother, and he was a heathen, and said, "Mom, that's me. Find out where that person is. I need help." So this person managed to come to Oakland Children's Hospital, managed to have supports to become the transgender woman that she is today. And this was before we even had a clinic. So absolutely want to underline what Andrea and Kristin are saying is kids have a place to go, and they have mirrors for themselves to be able to go, aha, that's me, and it's okay. It's not negative, it's positive.
Thank you. There were a few questions about parents regarding how can we help parents to support their children. It's probably the best way to ask that question, because clearly they may not be seeing eye to eye with where the children are. And how do we help, I guess, children navigate this, parents navigate this, the families navigate this?
The beautiful triad of pediatric medicine, right, is the parent or guardian, the child, and the provider. And so it's very rare that family presents to our clinic where the parents and the youth, or the guardian and the youth, is on the exact same page. And that's the beauty of the work that I think that we're doing, is that we're not trying to convince the parent or trying to convince the child that somebody's right, but really meeting the parent where they are, meeting the child where they are, and making a plan moving forward. And sometimes that starts with, something very simple is the outcome of the first hour and a half visit, which is there a safe place in the home where this child can safely explore their gender, right? Maybe that's a certain area of the house where the right pronouns will be used and the right name will be used, where they can experience that type of affirmation from their family. Or maybe, maybe we need to connect with a faith-based person in the community, right? If there's a barrier there in terms of just understanding what the youth might be going through internally. And maybe they're not seeking medical care at all. They're just seeking some sort of acknowledgement of the distress that they're experiencing. And so it really is not something that happens in one clinical visit. I think it's something that happens over time. And we just have to acknowledge where each person is coming to the table from and meet them right there. And that's where we start.
And I wanted to build on exactly that's where we start, but never where we finish. And there's 3 concepts that I have found really helpful in working with parents. One is, we talk about a gender spectrum, but there's also a parental acceptance spectrum. So where you start out when you're first learning that your child has something going on around the gender, it's not where you're going to end up. And it's a process, and the parents need to be heard, because I noticed there was a question about, so what if a parent says, I never saw this. There was nothing that ever indicated that my child would have gender undermined. Well, we listen to that. They're experts around their kids. They may not ever have had the opportunity to even see it, but we start from there. But I start from a cognitive dissonance model, and it goes like this. I love my child when they were born. I looked at them, I loved them. And now I'm learning they're one of those people, perhaps I don't love, that is transgender people. And so there may be, for example, some internalized transphobia. So they have this conflict. Either I change my views about gender, or I have to reject my child. And I'm an eternal optimist that love conquers all. That if we tap on the love component, we can move the gender, the parental acceptance bead towards acceptance. And somebody asked about support. There's all different kinds of support. What we're talking about here is to get a child's gender in focus and to be able to accept that gender. And it may be that they were using gender for other reasons, and the support would be accepting that actually they're not transgender, for example, but there was something else. So, but it is an acceptance model as a form of support. The last thing is the notion of gender literacy that I mentioned before. We all need it. We all need to be updated on new thinking, new research, new understandings of gender. I had to unlearn most of what I learned in graduate school as part of my gender literacy to be effective at our clinic. So I would say those 3 for parents. And I heard a lot of parents do not want to be in any kind of support group. A lot of kids don't want to be in any kind of support group. Not everybody is a candidate for a support group, but everybody is a candidate to have somebody who's a consultant who can support them.
Wonderful. I want to take a moment to share the screen with our check-in information here, since I know people are going to have to start wrapping up to go. And it's very clear there are a ton more questions here, and we're not going to be able to get to all of them. Some of the questions really have to do with this crisis and access. And like, what are the plans for the East Bay? How about way up here for our North? Any quick thoughts on like,
yeah,
if there
I
are
can to that quickly. There are plans right now in terms of expansion, and there's acknowledgement from the administration about the wait list and the risk of having a wait list this long. And so there are current plans to expand very significantly. Right now, I'm the only full-time medical provider in the East Bay Gender Clinic, and we just brought in a medical director, Dr. Nip, who's training and seeing very limited new patients. And so this will expand pretty significantly. I don't want to say specific numbers, but I mean, probably tripling or quadrupling our current staff. And so building a model around that and increasing access is a primary goal in the clinic right now.
Fantastic. And related to this question of access is, what is the role of primary care, or like what can primary care like kind of help step in to do? And I think this is going to be a whole other presentation, and maybe not something that we can talk about right now, because clearly there's a need for follow-up talk based on a lot of these questions. But if you had quick thoughts as to this is what you think you can do, and these are some resources you can go to, I think that'd be fantastic.
Yeah, I'll say I think the primary resource, and I don't know, Kristin, if you want to jump in, or Diane, but the Mind the Gap is a great resource, and there's a website. It's genderyouthproviders.com, where parents can access gender affirming and gender trained mental health providers. I know that it's difficult to access because it's difficult to find someone within your insurance and in your geographical location. And right now doing in-person versus telehealth, but it's a really good place to start. And there's a lot of community organizations too that offer support to continue the conversation and really start the conversation between youth and child, or between youth and guardian, because that conversation and that work can certainly start while they're on the wait list to access our clinic, and can be very beneficial, I think, for a family. And I don't know, Kristin and Diane, if you want to jump in.
That I would just say that one of the reasons we started Mind the Gap is not only so we could train ourselves, but train more providers, because mental health is the best of times and the worst of times around gender affirmative care. So we're trying to make it the best of times and really teaching more, or just and learning more about how to provide the best mental health care. So we welcome new members, and people can they can certainly contact me if anybody's interested in wanting to know more. And we are definitely swelling at the seams in terms of trying to meet the demand.
Well, thank you so much, Dr. Ehrensaft, Avicolli, and Pedersen, for this very informative talk today. Clearly, there will be a follow-up talk addressing some of these other questions that have come up through the chat. We'll be recording this, and the presenters did give permission, I think, for us to post these slides up on our website. And so they should be available along with our recording in another few days. Thanks for attending, everybody. Those of you who could join us today, and hope to see you next month, Thursday, June 9th, talking about eating disorders.